My name is Venkat Narayan. It's my pleasure to welcome my friend Michael Roden today. And so, good morning, good afternoon, good evening, depending on where you are. I know the audience is international. So briefly, Mike Roden is a professor of endocrinology and director of the German Diabetes Institute in Düsseldorf. He's also a very accomplished individual, well known in science, a member of the German Council, a member of the German National Academy, and also strong collaborative links with Japan. I had the pleasure of working closely with Mike Roden for 3 years. We used to meet twice a year in Kuwait. We both served on the board of the Dasman Diabetes Institute advising Kuwait. That's where I got to know Michael quite well, and we've even traveled together on Turkish Airlines, once or twice. So he's a very thoughtful individual, very thorough in his knowledge of diabetes across the spectrum. And some months ago, he and a colleague wrote a very critical and thoughtful paper on diabetes phenotypes. And as you all know, our center, the Emory Global Diabetes Research Center, is also paying a lot of attention to diabetes phenotypes, particularly interested in differences in ethnic distributions of these phenotypes. So I thought I would invite Michael to give us his high-level thoughts on this topic. That's what he's going to do today. So thank you all for joining. I know yesterday was a holiday, so the announcement went out late, but in spite of that, I'm seeing a large number of people already attending. So with that, Michael, why don't you take it away, and you can talk for about 45 to 5 minutes, and then there'll be some questions at the end. So thank you very much, Michael, for doing this online. Hope to have you in person in Atlanta in the near future.
Thank you, Venkat, for the very nice introduction. Indeed, it was always very nice when we talked about some aspects of diabetes. Let's say not in the traditional way of thinking when we were in Kuwait, but also on alternative ways to analyze or understand diabetes as a problem. So my task for today is to talk to you about diabetes phenotypes, and it will be mainly based on data that we have accumulated, showing a way where this phenotyping or subphenotyping might go, but also pointing to some challenges, and probably, of course, not all of them, but at least some of them, which we are facing today. This is my disclosures, which I always show. And let me start. So it's the classical old-fashioned way to start with history. So usually I don't do that. But in this case, it's probably quite interesting to see how the evolution of the classification of diabetes types went over, let's say, hundreds of years. And actually, the first person to more or less try to separate diabetes types was Professor Etienne Lancereau in the 19th century. And he divided diabetes in a diabète maigre and a diabète grasse, which means a lean and a fat diabetes. And actually, until today, we didn't move so much ahead from this basic concept. And then there was a time which actually started after the First World War. And at this time, it was when actually I learned that when one of the previous editors of Diabetology came to Vienna and was interested in history of diabetes, that he located one of the first individuals to further subtype diabetes, came from Vienna, and his name was Dr. Falter, who separated an insulin from an insulin-resistant diabetes. A little bit more than Lancereau has done before, but still not a lot. And it was then actually Harold Himsworth, who is very well known for his contributions, who more or less refined this system introduced by Wilhelm Falter into an insulin-sensitive and insulin-insensitive type, And he was the first to also introduce the test, the glucose insulin test, to separate these diabetes types. And there was then, I would say, another series of important individuals who, on the other hand, did only refine a little bit or rename or try to rename, but the basic concept remained until the 1950s and even to the 1960s, where the WHO was the first then to come up with an expert committee and then separating the diabetes types in what you can an infantile, childhood, young, adult, and whatsoever. So it was mainly based on age rather than on specific pathophysiological features of the disease, which took then another 15 years or so until then the American Diabetes Association and WHO in the 1970s and 1980s came up with this insulin-dependent and non-insulin dependent diabetes, which has not been refined much except for saying type 1 or type 2, a nomenclature which has actually been also used in the 1950s. And it was only very few years ago that Mark McCarthy wrote a very nice review challenging the overall concept and introducing other features such as molecular taxonomy in order to better understand subtypes of diabetes. So you see that at least in the field of diabetes, in diabetes research, it has taken from the 1880s to more or less a few years ago to come to different approaches for classifying diabetes. And the most important type of diabetes is, as you know, type 2 diabetes. Importance here means the most frequent because it's, let's say, depending on the population, 85 to more than 90% of the cases with diabetes that suffer from this classical type 2 diabetes. And to be honest, together with my friend Jerry Schulman, with whom we have been collaborating frequently over the last 20 years or so, we summarized the unified concept which evolved over long times and which is based on the critical and central role of the adipose tissue. And I have to I have to say here that actually we believe that there's really a unified concept in contrast to the topic of my talk. So saying that it is overall the adipose tissue which becomes dysfunctional, releases adipocytokines, releases fatty acids, which then drives the insulin resistance in the liver, in the skeletal muscle, and of course also has direct and indirect effects on the brain and receives input from the gut nutrient signals, which then form this integrative biology of type 2 diabetes. Point is that we, on the other hand, know that this does not fully explain the features of the classical type 2 diabetes. And we started off, and most of the data that I show you will be from this German diabetes study, which we established now just when I came to Germany about almost 15 years ago, that we tried to build up a cohort of people with recent onset diabetes and to follow them regularly over the course of at least 20 years and include both type 1 and type 2 diabetes and trying to get as much as possible information using imaging technology, using multiomics, and also phenotyping, not only the metabolic features, but also the complications and comorbidities, at least with the instruments and technologies that we had available now 15 years ago. This is not more than probably a case study because we don't have more than 2,000 people, but at least the benefit of this study is that they are very well phenotyped. And what we found with that already a few years ago, that when we do the basic phenotyping, which is the criteria for more or less separating type 1 and type 2 diabetes, simply by measuring insulin secretion and insulin sensitivity by gold standard technology, the panels here show you that people with diabetes do not follow the paradigm that all the people with type 2 diabetes have an increased insulin secretion in order to compensate for their insulin resistance. Indeed, even at diagnosis, there is a substantial number of people with type 2 diabetes which have a deficient insulin secretion almost similar to people with type 1 diabetes. And on the other hand, there's a substantial number of people with type 2 diabetes which are quite normal with regard to their insulin sensitivity. And the same also holds true to a certain extent for people with type 1 diabetes. But that already shows the large spread of the key variables which we use to define type 1 and type 2 diabetes. The panel on the right side introduces then the antibody positivity or negativity, which further on underlines that there is more than classical type 1 and type 2 diabetes. And when we had published that more or less at the same time or a little bit later, the ADA came up with a statement saying that the traditional paradigms of type 1 and type 2 might not longer be accurate, but both are heterogeneous diseases with different presentation and progression over time. Although there was not clear evidence from studies for this statement, it probably holds true, particularly with the studies that were published over the last few years. And then came the paper by Life Group's group at Lund University, where they used the concept of an unbiased cluster analysis. So they identified among the available basic phenotyping measures, they identified that with the use of 5 simple variables, which is glycemic control from HbA1c, body mass index, age at diagnosis of diabetes, and HOMA-B and HOMA-IR, plus the knowledge of one of the islet-directed antibodies, the GATT antibodies, they were able, with a nearest centroid approach, to assign each patient of their large Swedish cohort to a cluster which is primarily defined by one of these variables. So which is then glycemic control, body mass, age, and insulin secretion from HOMA-B and insulin resistance from HOMA-IR. And they identified these 5 clusters, which are named here: severe autoimmune, severe insulin deficient, severe insulin resistant, and mild obesity-related or age-related diabetes, making the point that type 1 diabetes is more or less identical to the severe autoimmune diabetes because it's based on the presence of GATT antibodies, whereas the 4 other types would be then building the classical type 2 diabetes. And that is actually what they did here in their paper, where the first author is Emma Alquist from the Scandinavian Andes cohort. And I think the major finding in this cohort is actually summarized here, which is that there is a substantial difference in glycemia between these cohorts, and that this difference in glycemia does not relate to endpoints. So they had, over a mean duration of 6 or more years, marked difference between the cumulative incidence of cardiovascular endpoints. And please check the green lines and the green arrows. The severe insulin-resistant diabetes phenotype or endotype has a quite good glycemic control over the period during which there was a markedly higher incidence of cardiovascular complications. pointing to what we know from other studies, that the glycemic control per se cannot or insufficiently explains cardiovascular outcomes. And then we, in our cohort, we used the same way of clustering. So we did not do the clustering, what we actually do right now, unbiased, but we used their clustering variables to more or less use our cohort and then address all the patients to one of these clusters. And interestingly, the distribution of the subtypes or endotypes was quite similar to the Swedish cohort. We found that we actually the first thing we did is we proved that their concept of using the HOMA indices is valid, because before this study, there was a lot of discussion about the use of HOMA index in people with diabetes, because the HOMA index is based on the relationship between insulin secretion and sensitivity in more or less healthy or insulin-resistant people, where the interaction between insulin secretion and insulin-responsive tissue is still intact. With the decrease of insulin secretion, which is known for the onset of diabetes, this relationship is disturbed, so that the question is, can the HOMA index really used in people with diabetes? So actually we found that it's possible using independent techniques to measure insulin secretion and insulin sensitivity. We found that really the insulin resistant phenotype in green, the SIRT, shows the lowest insulin sensitivity but highest insulin secretion. And we also found that over the time of diagnosis, 0 time to 5 years, we see an overall decline, which is differently occurring in the different subgroups of type 2 diabetes. We also found that, and that was actually confirming the Swedish cohort, that nephropathy based on EGFR at diagnosis is higher already in this, particularly the severe insulin-resistant phenotype. We found that it's a little bit different for neuropathy, where the severe insulin deficient and more hyperglycemic phenotype has a higher risk for neuropathy already at the diagnosis of disease. And more recently, we found that there is a quite interesting distribution for erectile dysfunction, which is known to result both from glycemia as well as from insulin resistance, which seems to be quite nicely mirrored here, as it's both the severe insulin deficient and insulin resistant phenotypes have the highest prevalence of erectile dysfunction at beginning of disease. And we finally confirmed, at least from risk surrogates, so not from hard endpoints, but using the Framingham risk score, but also others, that the severe insulin-resistant phenotype is the one that has the highest cardiovascular risk. We also, and that was a specific feature, we found that the subgroup of the insulin-resistant people is the one that has the highest liver fat content and the highest increase of liver fat content, as well as risk of liver fibrosis compared to the other phenotypes. And more recently, we also analyzed an interaction between, let's say, the acquired factors, because the current phenotypes, or let's say the surrogates used for phenotyping, can most likely be explained by, at least to a certain extent, by acquired factors, which relates to insulin resistance and, of course, the aging process and glycemic control. But we tried to analyze if there's also interaction between genes. So there are some genes that are known to markedly increase the risk for fatty liver disease, as well as for progression to fibrosis and cirrhosis. And the most important is PNPLA3, which encodes for a protein which is relevant and important for triglyceride composition as a hydrolase in the lipid droplets. A dysfunction of this gene leads to increased storage of lipid droplets and less release and less oxidation of fat. And when we then analyzed the frequency of the risk allele, which is a G, of this PNPLA3 gene, we found that in the severe insulin-resistant group, there is a higher distribution of the risk allele. And actually, in the severe insulin-resistant group, those who are the carriers of the risk allele actually also have a higher adipose tissue insulin resistance and independently of their liver fat content, which from this very clinical study brought us or supports a concept that this gene is not only important and relevant for the liver, in the liver, but also in the adipose tissue where this hydrolase is also present, and it would allow a hypothesis where actually the adipose tissue dysfunction with increased release of fatty acids, which is relevant for adipose tissue insulin resistance, explains the severe progression of liver disease, not only from an intrahepatic, but also from an extrahepatic point of view. I'm going over on this one. We also analyzed or performed the first analysis of biomarkers of subclinical inflammation and immune reactions. And as you can see, there are substantial differences between the groups. And it's, again, particularly the severe insulin-resistant phenotype, which shows differences. This is moving forward, sorry, in parameters indicating not only advanced glycation, but also really inflammation, higher release of interleukin-6, but also a higher prevalence of immune cell ratios, which indicate immune reaction and inflammation. So based on that, and this is from a German newspaper, there was this got some interest from the media, and people now make the point: is it now already the time to subtype diabetes, and should we in clinical practice move from just saying type 2 diabetes to these subtypes, and would that have any consequence? And in our original paper, but also later on, we tried to address these open questions. So what we have done and what the Swedish group has done, and now it actually has been repeated by others and confirmed in many cases, is this phenomenic clustering really something which is relevant? So when we use, on one hand, categorical versus continuous variables, does it make sense on the long run? Would these endotypes persist over time? For the current phenotyping, we use only one islet antibody. So if we would use more islet antibodies, would that change the distribution of the phenotypes? Is it relevant for other ethnic groups? Is it reproducible? And finally, is there any evidence that it's practicable, and can it be used for tailored prevention and treatment? One answer is given on the right side. Surprisingly, the membership to one cluster remains quite stable over time. There is some kind of movement, but in general, most of the people belonging to one cluster remain. We still do not know what is the impact or what is the influence factors that drive movement from one cluster to another one, which is currently under investigation and needs a higher number of participants to get better results. This is just showing that this and related phenotyping clustering has been used or is currently used Most of these approaches in similar or much larger studies or cohorts have tried to use, or have tried to be even more simple, trying to avoid the use of the HOMA index, which means fasting and insulin and glucose measurements. And still they come to quite similar results with some kind of modifications. This is one study that actually used the large IMI-Rhapsody cohort from Europe, where they used, instead of the HOMA index, the HDL and simply fasting C-peptide. And they ended up in similar subgroups of SID, SIRT, MOD, and MART, which they divided into two subtypes, which is not so relevant. Interestingly, they also found that there is some relationship between the membership to one of these endotypes and genetic variants, particularly with those of defective insulin secretion, which one would expect for the severe insulin deficient phenotype. And they also found interesting metabolomics and transcriptomics findings, which confirmed that particularly fatty acids and lipotoxic lipids, such as diacylglycerols, are enriched in the severe insulin resistant phenotype, which underlines or seems at least to confirm the pathogenic concept that the lipids are driving the insulin resistance, at least in the obese and the severe insulin resistant phenotypes. I have to say that there's also a basic or fundamental difference between clustering based on phenotypes, which I've shown you before, and the alternative clustering on genetic variants. The fundamental difference is that, of course, one would expect, if you can perform clustering simply based on genetic variability, this should be much stronger because the genes would not alter, whereas the phenotypes might alter over time or be not only just by aging process, but also by interfering treatments, medication, and whatsoever. And the alternative clustering has been used by Marco Laxo and colleagues, again from a Nordish cohort, where they used the GWAS for, at least at this time, the 94 most important known type 2 diabetes variants, plus 47 diabetes-related traits. Again, an unbiased approach. And surprisingly, they ended up with a quite similar way of clustering. One was the insulin efficient, beta cell or pro-insulin based, and a more or less insulin resistant clustering based on obesity, lipodystrophy, and liver lipids, which at the end seems to be quite similar to what has been found for the phenotypic based clustering. So where we are at the moment, I think we are still at the moment at the beginning of precision diabetology, trying to find subtypes which at best might help for precision diagnostics. Still, we do not know a lot about predictive algorithms, and finally also the relevance for treatment and prevention. One of the ways forward is from one of my colleagues, whom I'm just recruited to Düsseldorf as a professor of experimental diabetology, Professor Robert Wagner, who came from Tübingen, and he used another way of unbiased clustering, but not in people with diabetes, but in those with prediabetes, based on severe insulin resistance or family history of diabetes. And his way ended up in 6 endotypes, which also are quite similar to the 5 endotypes that we find in people with new onset diabetes. And he also separated them based on differences in cardiovascular risk. And it's particularly the insulin resistant liver fat, visceral fat cluster 5, which has the highest risk for not only developing type 2 diabetes, but also for increased cardiovascular risk. So clustering can be also applied to those with risk of diabetes, but without overt diabetes. And there's another paper just coming up and supporting that for people with severe obesity undergoing bariatric surgery. I don't want to go into detail here on that one. And we also have some initial data with regard to the effects on drug treatment. And that is from Dr. Dennis and colleagues, published after our paper and Professor Group's paper, where they actually challenged the concept that the use of the clustering has only a moderate value for drug treatment, at least with regard to glycemic control. It doesn't tell you anything about cardiovascular or other endpoints, but with regard to glycemic control, they found that the information on clusters is less relevant than the information of age alone, as you can see from the right panel, where it's just the elderly which would have a difference compared to the young with regard to the efficacy of classical anti-diabetic treatments with metformin, sulfonylurea, and thiazolidinediones to improve glycemic control. So that would challenge the concept that it's relevant for treatment, but this is still an open issue. And let me just introduce here very, very briefly a very simple concept that with regard to treatment response, precision treatment would need to meet two basic preconditions: that the individuals differ in their response, or that they are clinical predictors, which would allow to identify individuals with different response. And one of my colleagues at the center has performed the test with the available RCTs on glycemia as an outcome. And he found that when he used the test data, that the individuals differing in their response to treatment would not allow to find statistically different differences. But when he then went for the different drugs that are available, at least for GLP-1 receptor agonists, there was at least a trend towards a role of precision treatment, which would be relevant for using the clustering. So if there's a cluster that specifically responds to GLP-1 receptor treatment, this could be one way for making use of the clusters for precision diabetology. Another retrospective studies used the origin data, and they found some evidence that the SERT and the SIT endotype would show differences with a higher risk for cardiovascular endpoints as well as for diabetic retinopathy, which would now support the concept that, at least with regard to insulin treatment, the knowledge of the endotypes might have an add-on value with regard to these endpoints. This is probably something I would skip. And finally, coming to the next steps, I think what we are now need is prospective trials. All the information of the use of clustering for treatment efficacy is based on retrospective analysis and is based on glycemic control at best. So what we need is intervention, may it be nutrition or medication, by comparing head-to-head different subtypes. And one of these studies has been started here in Germany in our National Diabetes Center, which is a network of the centers in Munich and Dresden and Tübingen, in Berlin and in Düsseldorf, along with associate partners from Heidelberg and others, where we now try to use the concept of intermittent fasting, which has been, I think it's still under discussion, but at least it has some efficacy to improve glycemic control and weight loss. And we will use that now to compare the efficacy with regard to glycemic control and surrogates in one sample from the severe insulin deficient and one sample from the insulin resistant phenotype. And we are particularly interested, of course, if this would have differences with regard to improving insulin secretion or insulin sensitivity. Another next step has been already taken, and this is published most recently in Nature Medicine, where they have used, in addition to the phenotyping and genotyping, as I've shown you for Dr. Laxus and Dr. Life Group's concept, they also integrated other information from metabolomics, proinsulin, and whatsoever, which now makes it even more complex. And they have introduced a DDR3, where actually a person can be located into a three-dimensional or more dimensional room and try to bring that into a two-dimensional treat visualization, which is shown on the right side, which is still under discussion. We are now trying to collaborate and find if this would help for improved knowledge for precision medicine. It still doesn't integrate all of the data. We are still lacking information for fluxomics, which is much more important than simple metabolomics, which is just measuring a huge number of metabolites at one time point, but doesn't tell you anything about metabolic fluxes. We don't have any idea about the role of exposomics or psychosomics, all the very important influences which will be needed for a clear, real, multidimensional study. So I'm coming to the end. Clustering based on simple clinical variables is possible, allows to allocate humans with certain endotypes and with distinct metabolic alterations, and allows to identify differences in risk for comorbidities. Particularly, it's these severe insulin resistant and deficient phenotypes which show differences with regard to cardiovascular endpoints, renal endpoints, particularly prevalent in the insulin resistant group, and specific risk for the insulin deficient SID phenotype for polyneuropathy and diabetic retinopathy, and to a certain extent also cardiovascular disease. Knowledge of these endotypes might help to facilitate precision, but not personalized diabetology. So it's just stratified prevention or treatment. But we have the problem that at present no prospective study or analysis is available. So that's still a question mark. And we should not forget that overall lifestyle modification remains the overall driver of the progression of diabetes. And before we do not know more about specific treatment success in certain groups, this should remain the key, along with improved glycemic control and risk factor control, in order to improve the life of our patients in clinical practice. With this, this is just a slide summarizing as we see it at present, from coming from type 1 and type 2 diabetes to a more refined system with a lot of question marks. And with this, I thank you very much for the kind invitation and for listening for such a long time, and ready to take questions. Thank you.
Thank you, Michael. This is a very nice summary and very thoughtful. And thank you also for giving enough time for questions. So I'm going to open up the floor for questions. Do you want to stop sharing so that people can see each other? And
Vivek, be sure to check the chat.
Yeah, and I'll do that. And Mike, for some reason, you seem to have stopped my video.
Hello?
Can you let me
Hang
in,
on,
Mike?
Vivek. Oh.
Mark, I'm sorry. Yeah. So why don't we start with the first? There's already a question or two. Melinda Hagen. Melinda, do you want to ask your question or I can read it out?
Sure, no problem. Thank you so much. Wonderful presentation. I'm a biostatistician, so I was geeking out. I'll have to go back and read all these papers to understand all the cluster analysis. But I was just curious relative to some of the other sort of classic, outcomes in other conditions. If anybody's taken some of what you guys did and then also looked at chronic kidney disease and renal outcomes and things like that.
So I didn't understand the question. Sorry.
Sorry, I'll say it again. The clusters that you identified, for example, the severe insulin resistant one, I know that was highly correlated with a lot of cardiovascular disease outcomes. I'm just kind of curious, does it also correlate really well with chronic kidney disease and other renal outcomes?
Thank you. I've shown it on one slide, but did not really mention it in much detail. So we know from the available cohorts that the severe insulin resistant endotype is the one that shows the highest prevalence of early diabetic kidney disease at diagnosis, okay? Which means impaired EGFR, higher degree of microalbuminuria to a certain extent. And it also shows in our paper more rapid progression or decline in EGFR in the third group compared to the other groups. At present, I'm not aware of a study that really went for the clear-cut endpoints, which means dialysis. This I'm not aware. Is that answering your question?
Yes, sir. Thank you very much.
Any other questions? Or I have a number of questions. Would anybody else?
Hello, this is Lisa Steinmetz.
Lisa, hi Lisa. Yeah.
I have a question. This has been such a fascinating talk, and I was just wondering if, to your knowledge, presumably most of the data that you showed are from adults, and I was wondering if this has been done in youth who are also at risk for type 2 diabetes, and also interested to know about gestational diabetes, and if because women with gestational diabetes are at risk for type 2 diabetes. So wondering if you could comment on those populations.
So I'm not aware of any analysis for youth adolescents. So nowadays, I showed you one table very briefly that this, as you can assume, that this is a rapidly expanding field. So now many people are trying to do that in their cohorts, and that's very important and makes sense. I'm not aware of a good large analysis from any adolescent or youth group. Part of that might be due to the fact that a number of these studies has been done in Europe, and in Europe we still do not see a lot of people with type 2 diabetes or even with prediabetes. We now see more and more young people with overweight and obesity, yes, but it's still very, very much lower with regard to prevalence compared to the United States and other countries. And that's at least part of that. So cannot tell you. With regard to gestational diabetes, this is probably coming up very soon based on the analysis that my now co-worker, Robert Wagner, has done with his pre-diabetes cohort. So it's it lies on the table to do this analysis. I'm not aware that it has been done.
Yeah, this is Venkat. So again, picking up on Lisa's question, actually Yajnik from Pune published a paper in his cohort on diabetes and onset before the age of 45. And what they found was 60%, roughly 60% of the diabetes fell into the insulin deficient variety in that cohort of young onset diabetes under the age of 45. That takes me to the next question, which you kind of touched on, Michael, is that when you look across the world, I mean, over 50 to 60% of all diabetes cases come from either China or the Indian subcontinent. And when you look at the distribution of diabetes in these populations, number one, in the pre-diabetic variety, a high proportion is impaired fasting glucose in those populations than impaired glucose tolerance. And then the few studies that have been published on clustering, both in the US comparing the different ethnic groups and globally from India, from etc., seems to suggest that the clusters might be similar across global populations, but the frequency of the clusters are very different. I mean, like, for example, in the Indians, a higher proportion is the insulin deficient variety, may also be true in Africa, I don't know. But so I think I think here this introduces a huge gap in knowledge, because we are generalizing our findings based on studies in well-nourished Europe and well-nourished North America. So how do we expand this science of precision diabetes, not to miss the globe, which is where the real problems are happening?
Can I briefly share my screen again?
Okay.
I have one slide. Not sure if you see it. Do you see it?
Yeah.
Yeah. So this is actually, we have done that last year, and as we speak, I think these analyses are now coming up every month.
Yes.
These were the first papers from very different regions, and what you can compare here is that they use the identical way of phenotyping. Okay, so it's the there we have now this kind of which introduces another bias, that the variables are changing a little bit, which makes it even more difficult. But you can see here, this is the same clustering way, and you also see already here that there is a difference between the groups in also with regard to distribution. I think what is and I think you mentioned that the Indian cohort is very, very clearly higher in this severe insulin deficient phenotype, whereas on the other hand we see a much larger group of the severe insulin resistant in the classical, let's say, European countries. So we do not know, and of course that introduces the very important issue of the genes. So I think that what we learned from the most recent papers, I think we need to introduce a gene aspect to the phenotypes on one hand, and it still will not completely solve the problem, because we still do not integrate epigenetics, which is very important, and we do not integrate, which I mentioned at the end, all these socioeconomic and environmental factors. And we do not. I'm not aware that anyone nicely corrected for these factors. We always do that for other analysis, for prediction of diabetes, but for this analysis it has not been done.
Yeah, thanks. So Alex had another question, particularly related to lifestyle intervention. Alex Morshed, do you want to ask your question?
Sure. Can you hear me?
Yeah.
Yes.
Yes. Thank you so much. This is a really informative presentation. I am particularly interested in prevention, and you said that the science is evolving, but can you point to any time periods across the life course where these subtypes or phenotypes are particularly crucial? I know you have the age-related diabetes grouping, but otherwise, where it's important to think this way.
So probably I didn't fully understand. You mean the role of the age for intervention by lifestyle?
Excluding the age-related grouping, in terms of prevention, are there time periods in life when we need to consider this for prevention?
So I cannot give you an evidence-based answer. Maybe Venkat knows better. The only thing is from the experience that we have, for example, from the most severe experience in people with obesity and diabetes with bariatric surgery, you can perform it across a very broad age range, and you get more or less identical weight loss, and you get marked improvements of metabolism and remission of diabetes. So I think that the age is of minor importance. I think what is of major importance is that the severe insulin deficient phenotype seems to have the worst cards with regard to prevention and intervention. And that goes back to my old friend Roy Taylor's studies. And there are other studies, of course, but Roy Taylor did this. He actually starved the people, if I may say so. So they had something like less than 800 calories. And he could actually induce remission of type 2 diabetes in the majority of the people. And at the end, it was the group, he didn't do the endotyping, but it was the group with an initial defect or abnormality of insulin secretion, which responded less. So looking at his data, this is most likely the severe insulin deficient phenotype. And they had the lowest chance to have a long-term remission, independent of other factors. So I would say there is a difference, yes. And I think it's the most important group here is the severe insulin deficient phenotype.
Yeah, absolutely. I think related to that, all the diabetes prevention trials that are available today have been done in people with IGT, impaired glucose tolerance, who are an insulin resistant group, where the impact of lifestyle intervention is very powerful. But when you look at the few studies that have included impaired fasting glucose, isolated impaired fasting glucose, the effect is null, almost null. So in fact, Satish is doing a meta-analysis on it. So I think this is an exciting area. And the prevalence of impaired fasting glucose might be much larger globally than the prevalence of impaired glucose tolerance, which means we may have to think differently about lifestyle interventions and its generalizability. Before others have questions, I have a more provocative question for you, Michael. If you and Jerry Schulman were to write now, would you revise your unifying hypothesis?
Yeah, that's a good point. I would say, actually, I already in our review, I mentioned the endotypes. And even if it says integrative, the title is integrative, I don't know, pathophysiology or so of diabetes, we mentioned somewhere that there is already evidence for differences in the development of diabetes. Nevertheless, I would not fully rewrite it, because if we just take out the very important group of severe insulin deficient diabetes, which probably very important in India and some other areas, if you go to other areas in the world, it is the insulin resistant group, yes, but also the moderate obese group. And if you take both together, to me, the moderate obese group is just let's say a minor version of the severe insulin resistant group. And over time, as we have also shown over the first 5 years, these people, which is kind of interesting. So if you look at the liver fat, so everybody says 60 or 80% of the people with type 2 diabetes have fatty liver. That's true, but it's not true at the beginning of the disease, where it's only 15%. Because we have the data, almost nobody has this data. So point is that the moderate obese phenotype will more or less end up in the insulin resistant phenotype over time. And for these people, let's say for 60% of the people, 65, the concept of adipose tissue dysfunction remains key, and also remains the key for intervention.
Right. Okay, I agree. So Sandy, your question next.
Yes, thank you so much. It was such a great presentation. And I think you've kind of answered this as you've gone on, but I was thinking of how clinicians and researchers kind of want an answer of what is the best phenotype to use these days if you don't have genetic information available to provide that unbiased really snapshot. So what what guidance would you give? And based on the discussion, would it vary by population, by gender or ancestry group, given the global aspect as well?
Yeah.
So I guess that was kind of a loaded question, but it's sort of like, what do we do in the interim until things are really finalized or evolved?
So I agree. Genes is nothing for the clinical practitioner or the basic diabetologist or endocrinologist at the moment. The phenotypic clustering based on age, antibodies, and HOMA is something which could be used, although I'm not sure how this in the United States, but at least in Germany, in many areas in Europe, what I know, it's even difficult to measure the HOMA index because the insulin measurement is expensive. You don't get the people in the fasting state and so on and so forth. So, but there is both for prediabetes and diabetes a lot of ongoing, and it probably will end up that we can do a similar clustering without the HOMA index, probably with triglycerides and HDL or so. It's still under the way. Some find it. Actually, we at the moment cannot clearly see it in our group, but we have not fully investigated it. But if it's possible to transform what has been shown by avoiding to use insulin and fasting parameters, then it's possibly something to use, at least for the European cohorts. The performance for the other cohorts still questionable, not enough data, but also based on what is available, you probably can identify the SIT in the Indian population and also the other groups in the Japanese population. So yes, I would say it makes, you can do it. The only question is, as a clinician, I would ask you, what's the effect for the patient? So some of our colleagues in other universities have already, they are actually reporting that in their letters to the patients. Although we are the ones who publish the paper, we don't do it, because what is the diagnosis for a patient if I cannot offer evidence-based treatment? Okay? Yeah. So if a patient would ask me, I would give the information, but it's not a diagnosis for me because I don't have a treatment. So it's more or less, it could be a stigma, you know, and this is what I do not want for my patients.
Right, absolutely. And I was thinking more of looking at patient outcomes, you know, and figuring out how to tailor things more. But thank you so much. That was great. That was excellent.
So probably that was not the right answer, but that's how I see it.
Yeah, but Michael, you mentioned about HDL and triglycerides. Are there any published papers or unpublished data? Because the reason I'm asking is, Jitin Varghese, who's on the call, is actually writing a training grant on that very topic of alternative measures to insulin to the classification.
We are doing that, and if you look after this talk, I might check the list, or you might check the list in our diabetology review. There is at least 2 papers where they use the HDL. I can say that we, this is confidential or not, we are trying to use the triglyceride to HDL ratio. Happy to collaborate on that. Sure. We have published 20 years ago that the triglyceride over HDL ratio nicely correlates with insulin sensitivity in clinical chemistry many years ago. Right. So I thought that it's the perfect surrogate for the HOMA IR, but at least in our hands, I'm not entirely sure. So I think it should be investigated by someone who is interested, because the way is somewhere on that road.
Thanks a lot. Thanks. One final question, because we are past 11 o'clock. Charles, do you want to ask your question?
Yes. Can you hear me?
Yep.
Yes, it's Charlie O'Neill from the renal division. So I'm interested in what interaction there might be with blood pressure, and I'm supposing that blood pressure may differ between these clusters and may explain some of the propensity to CKD.
Yeah, good point. Interestingly, it didn't pop up during unbiased clustering in these cohorts. You know, so it's interesting. Fully agree, but it didn't pop up to be a relevant factor.
No, that's interesting, and thanks again for really a fabulous talk. I really enjoyed it.
Thank you very much.
Michael, can you take one final question from Melinda? Melinda has a question on whether anybody has looked at these phenotypes relative to various diabetes drug classes and downstream treatment effectiveness. I think you showed one slide.
Yeah. So that has been done by the UK group from the ADOPT study. And they used what the ADOPT study at that time used to compare for glycemic endpoints. And that was metformin, sulfonylurea, I'm not sure if it was glimepiride or another one, and thiazolidinediones, pioglitazone, rosiglitazone. I think it was pio. And this was the rather disappointing study where the simple knowledge of age was better to stratify people responding or non-responding, okay? And that's in contrast to other studies which are coming up or have been already published for insulin and other drugs. Still very difficult to, so if I would analyze these studies, you need to be aware that for these studies, they mostly use people with certain selection criteria. For the endpoint studies, they use, let's think about all these empagliflozin studies. They use people who already have a coronary heart disease or have CKD, okay? So with regard to the endpoint studies, you have a very high risk that you end up selecting the SERT or the MOT endotype, okay? So not the broad range, which would not allow you to sort out treatment differences.
Right. Yeah, I keep wondering, and there's this whole like chicken and egg kind of conversation, and I've been doing a lot of work with Sandy Dunbar over the years, and I know, you know, it seems like kidney disease, heart failure, you know, other cardiovascular outcomes, they're so comorbid. It almost makes me think that, you know, but yet we sort of, in terms of treatment paradigms, at least in the United States, right? Cardiovascular disease is sort of one area, nephrology is another area. But to me, it almost seems like it needs to be almost joint, or they at least need to be co-located in the same clinic, you know, to sort of sort out this like long-term treatment profile for people and figuring out all the different classes of diabetes drugs relative to cardiovascular outcomes and renal outcomes. Anyway, it's a fascinating, challenging area.
No, I would fully agree that the insulin-resistant endotypes cluster cardiovascular, kidney, and also liver endpoints. And that makes it so difficult to sort out, you know, if there is really the insulin resistance the common soil or not. Again, another question which we are not sure about, you know. But at least I believe, so just at the end, a pathophysiological point, I believe that there is some kind of abnormality which occurs with the development of insulin resistance, which ends up in inflammation and particularly fibrosis. And we are working on that in models. And the fibrosis is something which occurs in the heart, occurs in the kidney, and in the liver. And something along these pathways might probably be a common soil. But no clear proof for that at the moment.
Michael, thank you very much. I mean, you can tell from the questions that there's a lot of interest in this topic. So thank you very much for summarizing it. Thank you for taking the time, and promise to come and visit us in Atlanta next time.
I would be happy to do so. Also, you should come and visit us. and
course, yes.
very much enjoyed to have this interaction.
Yeah, wonderful. And let's talk. Yeah. Thank you very much, Michael.
Ciao. Bye-bye.
Bye-bye. Bye-bye.